Okay, I think we can start. So on behalf of the Faculty of Social Sciences at the University of Hong Kong, I welcome you to this much anticipated webinar. I know many of you are tuning in from different parts of the world, so good morning, good afternoon, and good evening. I suppose our distinguished guests today need no introduction. Those of us who have done any work related to depression surely would have studied his research. Some of his 900 plus publications have been cited over 1,000 times. But it is indeed my honor to introduce to you Professor Pim Kuipers from the Vrije Universiteit Amsterdam. Professor Kuipers is Professor of Clinical Psychology and head of the Department of Clinical, Neuro, and Developmental Psychology at VU Amsterdam. His H-index is well above 100, which puts him in the top 1% among his peers in the area of psychiatry and psychology. Professor Kuipers has generously agreed to give us 2 webinars. Some of you might have attended the one he delivered last month. If not, you can visit our Facebook page, and there you should be able to find the recording of that lecture. And this time, this afternoon, Hong Kong time, he will be enlightening us on the future of meta-analyses of psychological interventions. So we'll be asking Professor Kuipers to speak for around 50 to 55 minutes. Then we'll have ample time for a Q&A. So you can start typing in your questions in the Q&A box. You should be able to see that function on the bottom. And then later on during the Q&A session, I will be selecting and clustering different questions together, and then I'll pass them to Professor Kuipers. So without further ado, please join me in welcoming Professor Pim Kuipers. So the floor is yours, Professor.
Thank you very much, Christian, for the very nice introduction. And it's my pleasure to give this seminar. I think meta-analysis is a fascinating methodology, and especially in our field, I think it can contribute enormously to the further development of our field. So it's my pleasure to give this lecture on meta-analysis for psychological interventions. And yeah, it's nice that you're all here. I understand that there are a lot of people from Hong Kong, but also a lot of people from other parts of the world. So that's, for me, that's very nice. I never thought there would be so many people interested in meta-analysis at all, but I'm happy that you are. So I will start sharing my screen now so that you can see my presentation. Let's see. Here we are. I hope you can see this. If not, maybe you should give me a sign. But yeah, this is the title page. What I want to do today is I will briefly talk about why we need meta-analysis in the first place. Then I will give you a few links for resources that you can use if you want to learn how to do meta-analysis yourself, or if you want to use the data for meta-analysis. Then I will go what I call the Metapsy initiative, which is our initiative to collect all the data from randomized trials on psychotherapies for depression. And hopefully in the future, there will be added more psychological treatments for other disorders. Then I will show you the Metapsy website, which is interesting because there you can access our data directly, and you can make selections of studies and run your own meta-analysis online without going to any software or whatever. And I think that that will be a major step forward in meta-analysis, because the simple meta-analysis you can just do there on this website. So new meta-analysis have to come up with something more in depth, or something new, or something more than simple meta-analysis can do, because you can just run them on any subgroup, and on anything you want online. And then I will focus on new meta-analytic methods. So in the broader biomedical field, several new methodologies have been developed quite some time ago. But somehow this is not getting into the field of psychological therapies very easily. So I will talk about the most important new methods that have been developed and that are also useful for psychological interventions. And these are network meta-analysis, individual patient data meta-analysis, and I will briefly talk about umbrella reviews. So that's what I want to do this morning in this seminar. So let's go briefly. I mean, this is probably what you know, but I think it's still important to say a few words about why we need meta-analysis. Well, the problem is that the number of studies is increasing exponentially. For example, the number of randomized trials is huge. Like in 1965, when modern randomized trials started, we had 40 randomized trials. But now, when you look at PubMed and you look for publication type randomized trial, you find more than 500,000 randomized trials. And that would not be a problem if these trials would give the same outcomes, but they don't. Some are positive, depending on the field, of course. But then if I look at my field, psychotherapy for depression, you see studies with huge effect sizes, but you see also studies with negative effect sizes. So which one should you trust? The high quality ones, the large ones? Well, and in order to integrate the results of these randomized trials, you need meta-analysis. Meta-analysis are not perfect. They have a lot of problems, and the quality is often bad. And I won't go into detail about that. You know that already. Some people don't like meta-analysis. They say, yeah, but these large trials are better, and all these problems with meta-analysis. But in our field, for example, we have 750 randomized trials on psychotherapy for depression. If you don't like meta-analysis, what other way do you have to summarize the results of 750 trials? You cannot do that in a narrative way. So we need meta-analysis. Although they have all these problems, we need randomized trials, meta-analysis, in order to integrate the results of these individual studies. So this is what you see when you look at the new randomized trials per year. And what you see is that since the 60s, you see this huge increase in numbers of trials. In the last few years, you really can see a slowing down of the increase. So these are only the new meta-analysis from PubMed. I don't know why this decrease in the number of trials is happening. Maybe it's only temporary, maybe it's a financial issue, maybe people have enough of randomized trials. But anyway, that doesn't matter for our story. We still have this huge body of randomized trials, and that's increasing every year. Yeah, very briefly, meta-analysis started in the 1970s. And many people say it started with a presentation by Gene Glass at the American Educational Research Association meeting of 1975. There he presented the two core elements of meta-analysis of psychological interventions. One problem at that time was that many trials use different outcome measures. And so if you have two different outcome measures, you cannot just compare the results, because the 5 points on one scale is not the same as 5 points on another scale. So he came up with the idea of making a standardized outcome. So you do not look at the points difference on one scale, but you measure the difference between 2 points, so between 2 groups in standard deviations, what we nowadays call the effect size, or Cohen's d, or HSD, or standardized mean difference. That was a very good idea at that time. Now we are used to that, but he came up with that. And the second thing, which was the core element of modern meta-analysis, is that you cannot directly, you cannot just take the mean of 2 effect sizes, because one study is large and the other is small. So you have to weigh the size of the study when you pool effect sizes across studies. And these are still the 2 basic elements of meta-analysis: standardized effect sizes and pooling according to the weight of the study. Well, since then, of course, a lot of things have happened. We have the Cochrane collaboration, where this huge enterprise to get all these data together from across the whole biomedical field, including psychological interventions. Although the methods are, in my view, not often completely good for psychological interventions, but that's a different issue. Yeah, what you see is that also the number of meta-analysis is increasing. So this is the number of new meta-analysis published in PubMed every year. And you see this steep increase of new meta-analysis. Again, you see it's topping off somehow in recent years, but I don't know if that's true. But I mean, now we're getting to the problem that we have too many meta-analysis in one field, meaning that not only the number of trials is increasing so strongly, but even meta-analysis cannot do the trick in integrating the results of that. So we need another method to integrate the results of meta-analysis in a field. And that's where umbrella reviews come in. And that's why I thought it's a good idea to also briefly talk about that later in this seminar. So the next subject, a few resources. So if you want to learn how to do meta-analysis, you can download my book, which I wrote on meta-analysis. It's a free book. You can download it as EPUB or as PDF from my website, www.pimkuipers.com. Go to the tab meta-analysis. There you find these resources. It's an easy to read step-by-step methods of each of the steps you have to do when you do a meta-analysis. For each of the steps, I've recorded a YouTube video where you can go to my website to find the link, or you can just go to YouTube, fill in my name with meta-analysis, and then you find these lectures too. If you want to learn how to run meta-analysis in R, you can also go to another free book, which is free online, written by Matthias Harrer, Toshi Furukawa, David Ebert, and myself. And we've tried to make it as easy as possible to help you go through these meta-analysis in R step by step. Then the Metapsy initiative, that's also an important resource. You can find it at www.metapsy.org. And so I will come back to the resource later. I will first tell you a bit about this initiative. The basic idea is that we collect the randomized trials in psychological interventions for depression every year. So we do systematic searches, we update those searches every year, and then we have an up-to-date database of all randomized trials of psychological interventions for depression. We now have as I said, more than 750 randomized trials on psychological treatments of depression. So that's really huge. All the data are free. You can go to our website, www.metapsy.org, where you can download the data of psychotherapy versus control condition, not all the other data, because they make it open requires a lot of work, and we can spend our time only once. But you find all, the protocol, the characteristics that we have collected, the references of the studies, etc., the comparisons they examine. So do they compare psychotherapy versus control, or psychotherapy versus another, etc., etc. I've started with this in 2006. So that's almost 15 years ago. And since then, I have been updating this database every year. In the last years, together with my colleague, Irini Kariotaki, to make sure that everything is double rated. So it's a lot of work to do that every year, but it's a very nice resource. And if you want to read more about the meta-analysis we published about this, you should read an overview paper I wrote in Canadian Psychology in 2017. But since then, we have published many new meta-analysis again. So I think I should update that. So I assume that most of you know meta-analysis, and what I will try to do is I assume that you know the basics of meta-analysis, but I will try to explain things as easy as possible for those who are not as familiar with meta-analysis. So we work with effect sizes, Cohen's d or HSG. As I said, the difference between two groups after treatment in terms of standard deviations. We transform that to numbers needed to be treated. How many people do you have to treat in order to have one more positive outcome than no treatment? And here in this slide, you see how they correspond to each other. So an effect size of 0.5 indicates numbers needed to be treated of 6. So this is the number of trials. I worked on this a couple of years ago, but the trend is still there. So the trends are the same. Most trials were done in the United States until the mid-1990s. Since then, Europe has come in. And at this point, the number of trials in the US and Europe is comparable. But we also see that new trials are done in other countries, mostly in low and middle income countries, and especially in East Asia. So the number of trials outside the Western world is increasing rapidly. Overall, you see this exponential increase in randomized trials of psychological interventions for depression in general. So now we have more than 750 randomized trials. We can compare all these different types of psychotherapies to control conditions. We can compare different types of psychotherapies with other types of psychotherapy. We can compare it with pharmacotherapy, with combined treatments. We can look at inpatients, unguided interventions, treatment formats, group, individual, telephone, internet-based, etc., etc. So we have all these different data where we can write meta-analysis about. It's pretty exciting. I think I showed this one last time too, just very briefly. Here are the most important types of psychotherapy and their effect sizes. Based on the latest update so last January. Most psychotherapies have pretty large effect sizes. There are no significant differences between the therapies. I'll come back to that. But it does depend on the type of control group. So maybe we should not pool all these control groups in one analysis because they're really very different, with waiting lists having much larger effect sizes than care as usual or pill placebo or other control groups. Probably waiting lists overestimate the effects of psychological interventions because they stimulate people not to do the things they usually do to solve their problems because they are waiting for psychotherapy. So we looked, for example, also at the different kinds of care as usual. And we didn't find a difference between the different kinds of care as usual. So we consider no treatment also as care as usual because you cannot forbid people to get the treatment they want from the community for obvious reasons. So if you offer them no treatment, they can still go to their GP or go to a therapist or whatever. But if you look at the other care as usual categories, like care as usual in primary care or in general medical care, perinatal care, specialized mental health care, in each of these settings, if you look at psychotherapies, the difference between these categories of care as usual is not significantly different from each other. There is high heterogeneity. I won't go into that, but so if you look at category of care as usual and you look at countries, then you see clear differences. So it goes too far to go into too much depth here, but it's obvious that primary care in the United States is very different from primary care in China or in the Netherlands or in Africa. So, and the same is true for general medical care, perinatal care, et cetera, et cetera. So if you separate that out, you do find differences and you find very much lower levels of heterogeneity. So that's cool. It's not only, if you look at psychotherapies for depression, they don't only have an effect on depression. They also have an effect on other outcomes like quality of life, social functioning, hopelessness, social support. Unfortunately, there is very little research on the effects of psychotherapy for depression on suicidality, only a handful of trials, and the effects are not significant, but that may very well be a power problem. There is also this small group of studies in psychological treatment of depression in mothers. And when you look at the outcomes on children and parental functioning, you also find pretty good results. Of course, the number of trials is very small. So what else have we found? Well, as I said, we found no relevant differences between therapies. I will show a little more about that. We also didn't find any difference in whether you give psychotherapies in student populations, older adults, when people have a comorbid general medical disorder like diabetes or heart disease or cancer, perinatal depression, so antenatal and postpartum depression. Possibly there are lower effects when people have chronic depression, but that's much driven by a few studies on dysthymia, which do not have a high quality. So we're not very certain about that. Probably we also have lower effects when people have comorbid substance use problems. So then you find very small effects on depression and very small effects, non-significant effects on the substance use. But again, the number of studies is small. We also find smaller effects when you look at subthreshold depression. So people do not meet criteria for major depression, but still have some symptoms of depression. That's not so strange that the effects are smaller because there is less room for improvement. And we find in these studies that they probably prevent the onset of major depression at follow-up, according to a diagnostic interview. We also find smaller effects in inpatients, but that's probably because the control groups in the inpatient settings gets a lot of treatment anyway. When you're in an inpatient setting, you get a lot of treatment anyway. So another thing is that we did not find that the number of sessions is related to outcome. That's unexpected but true. So it really makes no difference for the effect sizes, whether you have 6 or 24 sessions. What we did find is that the frequency matters. So if you have 2 sessions per week, the effects are larger than you have 1 session per week or 1 session per 2 weeks. We have verified that in a randomized trial, a new randomized trial, and it seems that this is indeed the case. So it's validated that the frequency really matters. We also found that psychotherapies are probably more effective in low and middle income countries. That can be an artifact, it can be related to the quality of the studies. So the safest thing to say now is that psychotherapies are at least as effective in low and middle income countries as they are in high income Western countries. So when you compare it to pharmacotherapy, we've written many papers about it. If you want to read more about it, read our new network meta-analysis in World Psychiatry a couple of months ago. So in short, it says that psychotherapy and pharmacotherapy have comparable effects at the short term. Combined treatment is more effective than either one alone at the short term. But dropout is lower in psychotherapy and combined treatment compared to pharmacotherapy. At the longer term, probably psychotherapy is better and more effective, but even then, combined treatment is still better. And that's also true when you limit the studies only to chronic depression and to severe depression. So that's very briefly the psychotherapy versus pharmacotherapy discussion. We have examined many more aspects of this, but this is in brief the most important things clinicians would want to know. What you do have to remember when you look at studies for psychotherapy for depression is that the effects are heavily overestimated when you just pool the results. And that's because of several problems. We've written a lot about this too, so if you want to know more about that, here's a reference to one paper, but we've written many papers about this. First is, as I said already, the use of waiting list control groups, which can be problematic as they probably overestimate the effects of psychotherapies. Then the quality of the studies. So we use Cochrane risk of bias assessment tool. And then you see that the majority of studies, so about 80%, has at least some risk of bias. And the number of trials with low risk of bias is really very low. So everything is not certain. Then we have the problem of publication bias, small sample bias, I should say. But that's a big problem in psychotherapy research too, just as it is in research on antidepressants. And if you adjust for that, the effect size goes down with about 25%. We've examined this not only indirectly through meta-analytic methods, but also directly by looking at grants that were given by the NIH in the United States on psychotherapy for adult depression. And then we checked whether these studies were published. And we contacted people who got the grant but didn't publish the results, and we got most of the data. My colleague Alan Driessen did this, and we did this with Steve Holland, who's a very persistent man. And we found exactly what we find in the statistical methods to look at publication bias. But if you take all these problems together and you adjust the effect sizes for these problems, then you see that the effect sizes drop with about 50%, which is huge. So that's really a basic problem of our field, and we really need more rigorous, good, high quality research in our field. Okay, let's go to the next subject, the Metapsy website. So what we did earlier this year is we took the largest part of our data sets, which is psychotherapy versus control conditions. So for adults. So we have all the meta-analysis for psychotherapy versus control condition. We have put the data online. And with the shiny apps in R, you can make websites of that, where you can run meta-analysis directly online without downloading R, without doing anything. And that makes all data open and directly available for researchers, guideline developers, policymakers. And I will tell you later about our future plans, but we also hope to develop specific patient pages and clinician pages so that they can also get the data they want directly. So I've made screenshots, so I didn't dare to do this online because it often goes wrong. So I made screenshots to guide you through the website and show you a little how it works. So this is the start page. At the bottom, you see the colleagues who are involved in this. My colleague Irini Karyotaki, who leads this project together with me. Matthias Harrer and David Ebert from Germany, who are experts in our shiny apps and meta-analysis, and are also heavily involved in this initiative. Matthias is the one who developed this app. So this is the start page. In the left side of the website, you see a menu, and you see you can click on select data. If you go there and you click on it, you get to a new page. That looks like this. And here you see all the data with effect sizes of all the studies comparing psychotherapy for depression with control conditions. At the right side, you see a new menu where you can select data. So I will give an example. So you can select people on age, on target group, on recruitment type, on diagnosis, whether they have a comorbid mental disorder, intervention type, etc., etc. So if you want to examine, so let's see, I will give an example. So here you can select among all these categories at the right side of the screen. You can select anything you want. So for the example, I chose elderly among age categories, and among intervention type, I selected cognitive behavioral therapy. So then it means that I selected the studies on cognitive behavioral therapy for older adults. Then you go to the bottom of the screen, you click first on update table and then on run meta-analysis. And then you go to a new screen where you just got the results. So here you can see that CBT for older adults has an effect size of 0.75. Heterogeneity is very high, 78.77%. But you have much more. Here in this new menu, you can go to plots and see the forest plot. You can look at outliers with a Boccia plot. Outliers are automatically excluded in these analyses. You can look at publication bias. You get the risk of bias. So this means you can basically run a meta-analysis on any subject you want. Psychotherapy for psychotherapies in East Asia, group therapy for women with perinatal depression, guided self-help for people with general medical disorders. You can just select the studies and run your own meta-analysis online. No need to download the data, no need to write a paper. I mean, I see a lot of meta-analysis, and a lot of people do the searches all over again, do the data extraction, everything double rated, etc., etc. You don't have to do that anymore. The data are here. You can just run it directly online. So what we want to do next in this project, we did it early. We made this publicly available earlier this year because we wanted to have it out. But we will we will update it every year. So we have now, what you see now on the website is the update until January 1, 2019. We have updated the data now until January 1, 2020. We now write papers about this update. But at the end of this year, the data will be again available on the Metapsy website. So we have a little advantage to write a few papers about it ourselves before we open it up. But we are also working on making other data sets available. So we are working on, we will probably also open up the data comparing psychotherapy with pharmacotherapy and combined treatments, the data on inpatients, but we're also working on other data sets like panic and social anxiety disorder. We will make separate pages for patients and clinicians. We are also, I will come back to that later, working on shiny apps on individual patient data meta-analysis, and we will try to add these to the website too. So yeah, my dream is that in the next few years, we will build a full database of all psychological treatments for all mental disorders, with all the studies in there and as much as individual patient data available too. And it's very ambitious, it's a lot of work, but I really hope we can do this in the future, because I think it's a huge resource bringing the field much better. So let's go to the next subject, network meta-analysis. I already talked about this a little in my previous seminar. But I will try to show a little more about how you do the analysis actually. So basically what you do in a conventional meta-analysis, you examine one contrast, psychotherapy versus control group, psychotherapy versus pharmacotherapy, combined treatment versus psychotherapy. In network meta-analysis, you examine multiple comparisons at once in one large analysis. And it's not just a collection of multiple pairwise collection. You do more because you include not only direct, but also indirect evidence. And the methods have become much more easily available because the methods have been well developed now in Stata and in R, and you can do these analyses relatively easy now since a couple of years. Somehow they're not yet done much in psychological interventions, but I do think that they're very powerful, and they should be done more. Yeah, so I showed this last time too. This is the network plot, very important because it shows all the nodes you examine, the comparisons, the number of people in the nodes, so the treatments and control conditions, and the number of comparisons between the nodes. So here you see how this network works. So you have a lot of studies comparing guided self-help with waitlist. You have a lot of studies comparing individual therapy with care as usual, but you have no studies comparing care as usual with waitlist. and you have no studies comparing guided self-help with telephone. But you can estimate the difference between guided self-help and telephone-supported CBT indirectly. And that means that I explained this last time too, but for the ones who weren't here, who weren't present then, I explain it again briefly. So if you want to know whether group and individual therapy have comparable effects, then the best evidence is to look at studies directly comparing individual and group therapy. That's the direct evidence. But if you have studies comparing group CBT with waitlist, and you have studies comparing individual therapy with waitlists, then you can also estimate the difference between group and individual therapy indirectly. So if group versus individual has an effect size of 0, group versus waitlist has an effect size of 0.7, and individual versus waitlist has an effect size of 0.7, then the direct evidence says that the difference is 0, but also the indirect evidence says that there is 0 difference, because compared to waitlist, they both have an effect size of 0.7. So how do you do these meta-analyses? Well, one very important assumption of network meta-analysis is what is called the transitivity assumption. That means that because you include trials with different treatments, different comparisons, it has to be true that the participants in one trial could also receive the treatment in the other trials. And that's an assumption that you make when you do a network meta-analysis. And that's not always easy. There's no way of validating this. So if you, for example, you have psychotherapy versus waitlist control groups, but you also have studies comparing psychotherapy with pharmacotherapy. Are these the same patients? Can you add them in one network meta-analysis, assuming that the people who are willing to be randomized to therapy or waitlists are comparable to the people who are willing to be randomized to psychotherapy or pharmacotherapy? That's an assumption you make, and you're never certain whether that's true. You can validate it. I will tell you a little about it, but you cannot test it. So it is an important assumption. So how do you do these analyses? Well, first you just run all the pairwise meta-analysis you have. So so in the network meta-analysis I just showed you, you have all these comparisons between therapies, control conditions, and you just run pairwise meta-analysis for all the comparisons for which you have studies. Then you make the network plot. That's what I showed you also just now. Then you do the main analysis, and that's just running the software. It's not very complicated. I will show you the results later on. What you then do is also inspect the effect modifiers in order to get an idea of the transitivity assumption. So what you do is you look at the characteristics of the individual studies across the different comparisons, and then look whether the characteristics of these studies are comparable. Are people recruited in the same way? Is the diagnosis the same? Do they all use diagnostic interviews or a high score on a self-rating instrument? That kind of stuff. So you look at the potential effect modifiers and see whether they are equally divided across the different comparisons. You cannot test it because you don't have enough statistical power. So you have to do that visually. And that's the only way you can check the transitivity assumption. So that's one of the big disadvantages of network meta-analysis. The next step is to examine consistency, which means that you check whether the direct evidence and the indirect evidence point in the same direction. So that's not necessarily true. I've seen a few network meta-analysis, we did a few ourselves, where the direct and the indirect evidence do not point in the same direction. And then you have to find a solution for that. Is it the quality of the studies? Is it the period in which it was examined? Is it caused by publication bias, which sometimes is true? The next step is that you do grade, which is, you probably all know that, but then you grade the evidence and you look how strong the evidence is. There is software to help you with that for meta-analysis, which is called Cinema. It's really very great. Georgia Salanti, who is the main methodologist of this method, she also developed with her team the Cinema software. Really very cool, great work. So you can run network meta-analysis in Stata or in R, different methods. You can do it Bayesian or you can use it frequentist methods. But for now, this just goes too deep because I just want to briefly talk about the methods. And I see that I'm already talking for 45 minutes. So I go quickly. So this is what you get when you do a network meta-analysis. You, on the vertical axis, you see all the nodes. And then you can see in the lower left quadrant, you can see all the comparisons. You know, individual versus telephone, individual versus waitlist, unguided self-help versus group therapy. You find all effect sizes with our 95 confidence interval in a table like this. And the upper right quadrant of this table, we have given acceptability, but you can leave it empty or fill in anything else you want. But this is what you get. So you get all these different effect sizes. But usually it's much more better because how do you interpret all these effect sizes? So you usually get ranked forest plots, as they say, where you can where you give the effect sizes with one reference group. And here it's care as usual as a reference group. All kinds of other methods available, but because of time, I won't go into that too deeply. But it just gives you an idea of network meta-analysis. Then individual patients, individual participant data meta-analysis. This means that you just collect the primary data of identified studies. So you just do a normal pairwise meta-analysis or a network meta-analysis. And you send emails to all the authors and you ask them to give the data. Usually we ask them to be co-author because they contribute to the data collection. Of course, they have to meet criteria for authorship, but that stimulates people to give their data. The basic methods are the same as the conventional meta-analysis. So you have to have a PICO, you have to do the searches, you have to select studies, two independent raters, etc., risk of bias, etc., etc. But if you have the primary data, that has several advantages. You can do much better analysis. So randomized trials and conventional meta-analysis, they are powered to examine the effects of treatment, not to examine moderators. So they never have enough power to find significant predictors and moderators. So there are simulation studies showing that you have at least 4 times as many, you need at least 4 times as many people to find a significant moderator than to find the same significant effect. And that number explodes. So individual trials just don't have the power to examine predictors and moderators. So if you combine all these data, you do have sufficient power to find that. That's one really big advantage of IPD meta-analysis. But another advantage is that you can do the analysis the same across all these trials. So you can do intention to treat analysis, impute missing data, etc., using the same methodology. So that not only increases power, but also the precision of outcomes. Another advantage is that you can examine rare outcomes like deterioration. And like this is something which happens in about 5 to 10% of patients, that they actually get worse. But you can examine that in IPD meta-analysis. You cannot examine it in trials or in conventional meta-analysis because it's often not reported. But IPD meta-analysis, you can do that. Okay, I'll skip this. The steps you do is first, just like in conventional meta-analysis, do a systematic search, select studies in step 2. Step 3 is invite first authors to be part of a collaborative with formal emails. If they don't respond, you send a reminder. Otherwise, you send an email to the senior author and you try all authors. You collect the data from all randomized participants for the studies who give the data. You make a new separate database. So you first check the data against the published reports for accuracy. And that sounds easy, but it's often difficult to get that. So it's a lot of emails with the authors, etc. And then you recode the available variables into one universal variable that is available in multiple studies. That also sounds easy, but it's a lot of work, and it's not as straightforward as you think. Yeah, so then you have the data, you run the analysis. That's the easy part, right? That's usually the case. If you have the data, then you can run the analysis. It has a lot of challenges, of course. It's much more resource intensive than conventional meta-analysis. Relies on the willingness of collaborators. So what we usually do is we send emails on behalf of a group of prominent researchers. And then a researcher are more inclined to respond, that kind of stuff. Studies may not be able to contribute data. That's a problem. And that may not be random. So there could be selection bias. You can check that, of course, but you never know. You have varying outcome measurements. So then you have to standardize the outcome measures. And a big problem is that you only have available predictors that can be analyzed. I have to talk quickly. So this is one IPD meta-analysis on self-guided internet-based CBT we published. This is an IPD meta-analysis in which we compared CBT with pharmacotherapy and found that baseline severity is not related to outcome. So it's also in severe depression, CBT has comparable effects as pharmacotherapy. Here we looked at negative outcomes, but also very positive outcomes in CBT versus pharmacotherapy. So this is, I will skip that because it's mostly about the methods, and I've told you about that. I do want to show one more thing, which I think is the future of IPD meta-analysis. So this is about an individual patient data network meta-analysis led by Toshi Furukawa, was published in 2018 on CBESP, which is a type of psychotherapy for chronic depression. We only have 3 trials, but the trials were large. So we had a lot of data, but because these studies were so large and expensive and well done, We have a lot of variables we could examine as predictor. And what I want to show you is what they came up with. Another shiny app where you, I don't know if you can read it, it's not really that important. I just want to show you the principle. So in the left menu, a clinician or researcher or a patient can fill in individual characteristics of the patient, which have been found to be associated with the outcome in the IPD-NMA. Baseline severity, baseline anxiety, age, marital status, the diagnosis. And the lines in the graph indicate the course of depressive symptoms over time, over 12 weeks of treatment. Red is CBESP only, blue is medication, and purple is the combination of the two. And here for this patient, you see there's no difference. They have comparable effects. But for illustrative reasons, I made a screenshot of this because I didn't want to go to the website either, but you can go to this website yourself and check it out yourself. So for this patient, if this patient now has a low baseline anxiety, but if the same patient would have high baseline anxiety, you would get this. And then you see a clear difference that CBESP is less good for this patient. Medication is better, but clearly the combination of the two is much better. The nice thing about these shiny apps that it's relevant for individual patients. And we are now developing many more of these personalized predictor models which have these apps which you can find, which you can use as a clinician or a patient, so that you can see which treatments is best for you. Okay, let's go. I'm talking too much, so I'll go through this quickly. As I said in the beginning, we get too many meta-analysis anyway. So the next step is an umbrella review, which that's important because also meta-analysis do not get the same results. So if they would all point in the same results, but they don't. So what you can do is just you do an umbrella review. That's not really, the methods have not really been developed very well. But again, you do a PICO, systematic searches, you can extract data and you can go pretty deep into that. So you first extract data on the level of the meta-analysis. So you look at the subjects, characteristics, you rate the quality using the M-star quality here, risk. You can look at the overlap in number of included trials. But you can also extract data of the level of included studies. How many studies are included in each subcategory? How's the quality? You can standardize quality ratings given in the meta-analysis to a score between 1 and 0. And then you get, for each individual study, you also get a quality rating. So we did it for college students, psychological interventions for college students. So we had 14 meta-analysis on depression, anxiety, and stress, 12 on substance use, 5 on other problems. The number, you also see the number of meta-analysis with quality scores, and you see the mean M-star score of the meta-analysis. But you can also look at the study, the level of the college students, the primary studies. So in total, 600 studies, 305 in depression, anxiety, and stress, 192 in substance use. You see the percentage of studies included in only one meta-analysis. So the more the overlap, the less needed meta-analysis are. That's obvious, right? But you can also look, we also looked at the quality scores of the individual studies. So this is a brief overview of what you can do with umbrella reviews. So my conclusions: meta-analysis are powerful, needed, And they're so useful in integrating this growing body of research. I hope you liked the Metapsy project. And you, as I said, you can just go there, and I hope that it will be used a lot. And I've gone through new developments, network meta-analysis, IPD meta-analysis, and IPD network meta-analysis, and very briefly on umbrella reviews. I want to stop with a funny paper published in BMJ. In the Christmas issue, they always publish a funny paper, which is not meant seriously. And a couple of years ago, they published a paper about randomized trials to examine the effects of the use of parachutes when you jump out of a plane. And they said that they couldn't find any randomized trials examining the effects of the use of parachutes compared to not using a parachute when you jump out of a plane. And that's therefore the use of parachutes is not evidence-based. Meaning, and I think this is a good lesson, that you don't need randomized trials and meta-analysis for anything to keep your common sense. So, of course, I didn't do these meta-analysis alone, and there's a lot of people involved in this. And I want to thank you for your attention. If you have questions for me or you want to contribute to the Metapsy project, send me an email or look at my website, www.pimkuipers.com. Thank you for your attention. And I will stop sharing my screen now.
Fantastic. Thank you so much, Professor Kuipers. So that's a lot to digest, and I'm sure many of you would have questions related to the topic. So feel free to use the Q&A. We will have a prize for the nerdiest question. Just kidding. All right, so go ahead and shoot away. I already see some questions here. So I'm going to perhaps start reading some of them. Okay, the first one is on clinical significance, the threshold of clinical significance. Obviously, we have Cohen's D and Hedges G, and we use that sort of as shorthand or rule of thumbs. But doesn't it also depend on the type of treatment and the outcome, the severity outcome? So how do we understand these shorthands or these rule of thumbs vis-a-vis clinical significance? What would be your recommendation?
I think this is an excellent question. The problem with effect sizes, the standardized mean difference, is that it's still a statistical construct. So it indicates the difference between two groups in terms of standard deviations, but that's not related to the clinical relevance of the outcome. So for example, if you have an effect size of 0.2 in depression, that's considered to be small. But if that effect size of 0.2 would be about days or years of living, so about mortality, then it would be a huge effect. But if you would say, well, if you look at an effect size of 0.2 of a treatment on knowledge about depression, then people would usually say, well, an effect size of 0.2 improvement in knowledge of depression, that's not really clinically relevant. But if it's on mortality, it's a huge thing. So the effect size is a relative, it's a statistical thing, it does not indicate clinical relevance. And what I think, I wrote a paper about that in 2014 in depression and anxiety. What I think we should try to do is look at the minimally important difference. So that's a big research area. You can do that also for depression, and you can ask patients to indicate, there are methods for that, what is the minimal thing you would notice in improvements of depression. And then you could use that as a standard. And so then you have at least a threshold of what has relevance or not. So, I mean, of course, it's true that if you have an unguided intervention with no resources, with a small effect size, you can do that anyway. But if patients don't see the effect, then it's still not good to do that, because they invest time, et cetera, et cetera. And they hope for improvement, which they don't get. So I think we should try to find this minimally important difference. It's also important, you know, if you in clinical practice, if you have a doctor who has to consider, do I give drugs or do I give psychotherapy? And then this doctor, if there is a small difference, but clinically relevant, then the doctor will give that one. But if there is no clinically relevant difference, you can much more rely on what patients find relevant.
Thank you. And regarding IDA, or individual patient data meta-analysis, given that the field is pushing towards more an open science framework, would you say that should be the future of meta-analyses? Because we'll, in theory, we should have access to at least publicly funded clinical trials, the data of publicly funded clinical trials under the open science framework.
Yes, in principle it is, but at the same time you see a movement toward more data security. Anonymizing data is not enough anymore, because it's not like you take away the names and addresses and then it's anonymized. If you really want to do that, it's much more complicated. And so what we see in our IPD meta-analysis is that we increasingly see that we have to make data sharing agreements with authors who provide data, and that we can use these data only for the purposes of this IPD meta-analysis. So in principle, the data should be open, but we also have at the same time the problem that we have to have data sharing agreements because the data cannot be shared just like that. Personally, I would think it would be so wonderful if you do a randomized trial and give the data right away to open data frameworks. I mean, that would be wonderful. I don't think it will happen quickly. But of course, if you have these shiny apps, you can make the data not directly available, but you can make the results available. So even if the data are not open, you can still use them to make the results. So then you can still, patients can still use them to see what happens with themselves.
Thank you. There's another question on handling moderators. When there are numerous potential moderators in a meta-analysis, how do we draw inferences? Is multimodal inference the best or preferred option?
Yeah, that's a good question. Well, if you take conventional meta-analysis, moderators have to be handled very cautiously. Because there are simulation studies that you would need, you know, hundreds of studies to examine moderators well. And then you always have the problem in conventional meta-analysis that moderators are, they correlate a lot with each other. So if you find that group therapy is more effective than individual therapy, that's no evidence whatsoever that's actually true. Because it can very well be that studies on individual patients or individual therapies use more waiting list control groups and are often done in low and middle income countries. And these are so They are so interrelated with each other that you really cannot trust them. In IPD meta-analysis, it's different because then you have the primary data, and then it's also a matter of statistical power. So if you have a lot of moderators, you can look at the interactions, the moderators, and double interactions, et cetera, when you have enough data. And so in some IPD meta-analysis, the ones who are led by my colleague Irini Karyotaki, with the number of participants we have in these data sets is more than 10,000. So, and then you have large data sets where you can also look at interactions.
Right. So with individual patient or participant data meta-analysis, we get to have a more precise estimates of the effects of interactions and moderators.
Exactly.
And what's your take on missing data? What is a good rule of thumb for inclusion of a study if we were to set a threshold for missing data tolerance?
Yeah, that's a good point. Missing data is always complicated because missing data is we don't know why people drop out. And so we know, for example, that in internet-based therapies, the dropout is higher than in face-to-face therapies. And if there is so unguided internet therapies, the dropout is often more than 50, 60%. And then you don't know what happens to the people who drop out. There's no solution for that. So you can do the most sophisticated analysis you have, but you still don't know what happens to these people. Could be negative, could also in some cases be positive because people feel better and they just stop going to the treatment because they feel better and they don't need it anymore. We don't know. And so but yeah, I mean, in randomized trials and an IPD meta-analysis, we just impute missing data, and that's the state of the art.
Right.
There are more sophisticated methods now. So with a few statisticians, I wrote about that a couple of months ago. We will try to do that more in future studies. You assume that people drop out equally from treatment and control groups, but that's often not the case. So then you can trim the people in the control group if they drop out less than in the treatment group until the groups are equal, and then estimate the effects. And that's a more conservative, but also a more better way of estimating the impact of dropout on treatments. But I mean, that's a very methodological thing.
Mm-hmm. And it also sounds like with IPD, a lot of these issues can be handled with like multiple imputation or even FIML. So it sounds like IPD is the way forward if people are willing to generously share their data. Okay, so let's see, what's some other questions? Okay, so here's one about dose response. Is it possible and usual for including dose response analysis in network meta-analysis?
Yeah, let's see if I understand the question correctly. That means that you look at the number of sessions and the time investment in therapy, so to say, as a predictor of outcome. Of course, you can examine that. So in IPD meta-analysis, you can examine patient-level characteristics, but you can also examine study-level characteristics. The intensity of the treatment or the contact time or number of sessions is one of the study-level predictors. And of course, you can examine that in IPD meta-analysis. Yeah.
Right, so using multi-level strategies to analyze IPD datasets.
Yes.
Right.
Yes.
And this is a more general question from one of the attendees about pre-registration. I think this is the general trend that we are trying to pre-register our work. But I'm sure there are times when we wonder, after pre-registering our study, we realize the number of available study or the K is too low. What would be your recommendation in terms of a minimal K? I guess it also depends on the research question and the designs of the studies.
Yeah, I think these are two different questions. So you should register your protocol anyway, regardless of the number of trials you will find. So if you find only 3 trials which are relevant, that's also an outcome. So it's, I don't think that registration is related to the number of studies. Then I will come back to that in a minute because I want to say a little more about that. But if you ask for the number of trials for a meta-analysis, there's no good answer to that. It's not only the number of trials, it's also the size of the trials. It's the quality of the trials. So if you have 20 crap studies, it's no use to pool them either. But if you have 5 very large trials on a very relevant outcome, that's important to pool also. So there's no N of number of studies that need to be included. It depends on the number of participants, the quality of the studies, the importance of the outcome, and the expected outcome. These are the 5 parameters that you have to weigh in order to say whether it makes sense to do a meta-analysis or not. About registration, that's indeed a general thing in our field, which has come up very quickly. You should do that. I'm not sure whether it is really that important. The most important thing is that you specify in advance which moderators you will examine and how exactly you will do the analysis. But yeah, I'm not sure whether there's so much variability in the analysis you can do that pre-registration is always needed. But I mean, that's the tradition. So we have to follow the general rules. I have seen that Prospero was the most important registry for registering meta-analysis, but they're very slow. And so it can take several months before you get approval. So we now just go to the open science framework to register protocols, which works just as well.
Mm-hmm. Mm-hmm. Thank you. And another question concerns outcome variables in meta-analyses. A lot of times we look at symptom reduction alone, but is there a way to combine various outcome measures and combine them into a multivariate effect size so that we can have a more comprehensive view of the outcome of the treatment in question?
No, I don't think so. Because suppose you have depression, suicidality, and quality of life as outcome. So, but the measures you use, they use different constructs. So suicidality is not the same as depression, and quality of life is not the same as suicide. So then you make an assumption of effect sizes is that they measure the same latent construct. If they don't, you cannot pool them. So you cannot pool outcomes for suicidality and depression and quality of life. So you really have to stratify them across different outcomes, so to say. So I mean, I also think it's a good illustration for what an effect size means. If you have an effect size of 0.2 on suicidality, I think most people would be very happy. But if you have an effect size of 0.2 on depression, I mean, that's very small effect size, and you can wonder whether that's clinically relevant. If you have an effect size of 0.2 on quality of life, I think that would be pretty impressive. But they're not the same thing. And you cannot pool them because they're not the same thing. Yeah.
Thank you. So here's a question on network meta-analysis. Could you demonstrate how visual inspection of effect modifiers can be used to test the transitivity assumption? Thank you.
Yes, I understand that's difficult to explain. So what you do is you take all the comparisons you have. So for example, in our network meta-analysis of treatment format, you have individual versus group, individual versus telephone, individual versus guided self-help, group versus waitlist, et cetera, et cetera. So you have all these different comparisons, which are a lot in this case. Then you make a table with the characteristics of the studies. How were patients recruited? In which country? In which do they have a diagnosis of depression, or do they score high on a self-rating scale? So you take all these characteristics and you check whether these characteristics are evenly divided over the comparisons. And as you can imagine, then the number of characteristics and the number of comparisons is, you cannot test it. I mean, the numbers are so small. You can only visually, see, okay, for individual therapy, this was compared, the recruitment was the same as for group versus guided self-help, something like that. So if you find big differences, that means that these studies are not comparable. And then you violate the transitivity assumption. But of course, the transitivity assumptions goes much further. It assumes that the studies are comparable and that the patients randomized to all these interventions could have been randomized to any of the interventions. So you can check it with this cross step, so to say, but it's never enough to show that there is no transitivity.
Right. And taking a step back, here's another question related to the theoretical assumptions underlying network meta-analysis. So this person asked that it seems like network meta-analysis suggests that when A versus B and B versus C are available, then we can estimate the effect of A versus C. So the question is whether this kind of assumption or estimation is proper or legitimate, because this person used football matches as an example. If one team wins another team, and then team B wins team C, we can't really assume that team A and team C, when they are matched against each other, would show a predicted result. This person used the English Premier League as an example, but respecting Professor Kuipers, let's assume that we're talking about the league in the Netherlands.
Yeah, so I think the outcomes of football matches are more variable than what you would find for randomized trials. I like the comparison, by the way. So if you assume in meta-analysis that you have one outcome, so to say. So Liverpool is better than Barcelona, so to say. And Barcelona is better than Madrid. I don't know if I offend some people, but if you have one match, of course, that wouldn't say very much. But if you look at a whole season and you compare the outcomes of, and you have multiple games where Madrid and Barcelona play with Liverpool, et cetera, then I think you would get that's the assumption of competition in football, right? And in meta-analysis, you do not look at one match, but you look at the whole competition. And so if you see that Barcelona loses all the time from Madrid and it loses all the time from Liverpool, then probably Madrid is better than Barcelona, but also Liverpool is better than Barcelona. So they may have comparable outcomes, so to say.
And I'm sure people who are setting up the bets would agree. That's how they estimate the odds. Okay, great.
It is important to realize that it's indirect evidence.
Right.
So it's not like you don't randomize. So if you compare Liverpool with Madrid without randomized trials, it is an estimate based on indirect evidence. And that's not the same as direct evidence. So the level of evidence is lower. Yeah.
Mm-hmm. Mm-hmm. Another person asked about umbrella reviews, perhaps because we didn't have too much time to go over it. It seems like in one of your slides you said it is not a generally accepted method for how to do these studies. I didn't catch that line, but perhaps can you elaborate a little bit more?
Yeah, it's new. So we don't really know how to do them. That's what I wanted to say. We don't know how exactly do you do that. Usually if you would take one field, which is narrow, then you would say, okay, but then why do an umbrella review? You can just do a new meta-analysis in which you include all the studies in this field. So it has to be a field which is broader than one research question. And if you do that, then you still, so you, like the umbrella review we did on psychological interventions for any psychological problem in college students, then it's too broad for one meta-analysis. And it's too, then you can see, okay, how many meta-analyses have been done. And it's a lot of work if you extract all these data. But in the end, I think we got a pretty nice picture of the size of the fields, the quality of the studies, the outcomes, the effect sizes, the weak spots of the field, so to say, which you cannot do with a meta-analysis. And so, but how to do that? Yeah, I mean, we did it in a specific way, but I think at this point, all good ideas are welcome. All good ideas on how to contribute to the methodology are welcome.
Great, fantastic. And I'm aware of the time. We know that Professor Kuipers has another meeting soon. So I think we can close here. Just want to remind everyone that the slides and the recording of this talk, it should be available on the Faculty of Social Sciences Facebook page. And Professor Kuipers has also kindly offered the option of emailing him directly if you have further questions. I know that there are still a few questions out there that we probably don't have time to answer today. And I want to add a personal note. Professor Kuipers has been extremely generous with us. He even went out of his way to pre-record this lecture just in case there's any technical difficulties, but thankfully we didn't need to use that recording. But that shows his generosity and his willingness to share his insights and experience with us and the audience coming from different parts of the world. So we once again thank Professor Kuipers for the two excellent and insightful webinars. And we are sure that you have blessed and inspired many of us. And we look forward to our future collaborations in any form with Professor Kuipers. Perhaps one day when the COVID situation subsides, we will get to meet with everyone face to face. And until then, please take good care of your health and be safe. And we look forward to our next encounter. So thank you again, Professor Kuipers. We can each in our own respective bedroom or trail or office, clap our hands, and thank Professor Kaiser again. And so we'll end here, and thank you, everyone. Thank you.